Hello, my name is Sarah and I am a student at Southwest Baptist University. My research topic is negative pressure wound therapy with installation compared to standard negative pressure wound therapy. First, I will start off by explaining what exactly this therapy is. Negative pressure wound therapy with installation, more commonly called wound vac therapy, is a specialized dressing that works by applying negative pressure or suction to a wound and then instilling a prescribed solution for a desired length of time, also known as the dwell time. The current standard of wound vac therapy is negative pressure wound therapy without installation. It's basically the same thing as what I'm studying, except without the installation component. With my research, I was hoping to learn about evidence in support of or against negative pressure wound therapy with installation becoming the new standard of wound vac care therapy. There are many indications for use, such as acute and chronic wounds, traumatic and dehisced wounds, partial thickness burns, ulcers, flaps, and grafts. There are also contraindications to using this therapy, such as untreated osteomyelitis, malignant wounds, unexplored fistulas, exposed vasculature, and spinal cord injuries. There are many benefits to using negative pressure wound therapy with installation. It decreases the amount of bacteria in wounds, promotes granulation tissue formation, accelerates wound healing, helps to prepare wounds for grafting or skin flaps, reduces the average number of repeat surgical debridements and interventions, decreases length of hospital stay, and decreases overall healthcare costs associated with wound care. Now I'll talk about why this subject is important to me. I'm very passionate about this topic because I'm a burn trauma ICU nurse. I see wounds and different wound therapies every single day. From my own personal experience, I am amazed at how negative pressure wound therapy with installation works. It is amazing and revolutionary in my opinion. Wound vacs alone are beneficial, but when you add the installation component, it takes wound care to a whole new level. I was very excited to get to do my research about this topic because I'm just so ready to learn more about it. This topic is important to the public because of all the benefits. So many people who are admitted to the hospital or who are seen in clinics have wounds. So this therapy has the potential to help so many people by improving their overall wound healing, decreasing the amount of bacteria and infections in their wounds, and decreasing their costs and their hospital stays. This topic is important to the healthcare system because it decreases costs to the patients and to the hospital, decreases the amount of time the patient needs to spend in the hospital, and decreases repeat surgical interventions. It's important to the subjects of my review for every reason that I've mentioned previously. It also has improved wound care and wound healing and improved patient outcomes and patient satisfaction. My PICOT question is, for patients with acute, subacute, or chronic wounds, does negative pressure wound therapy with installation, when compared to standard negative pressure wound therapy, impact the overall healing process and decrease infection rates over a 3-month time period? The time period aspect of the PICOT question was the hardest part for me because each wound is so different. There are so many factors that contribute to wound healing, such as the type of wound itself, the wound care that has been received or is going to be received, nutrition, infection rates, comorbidities, and so many other things. Every wound is different, and healing a complex wound is not always a quick fix. It's a process, and sometimes it's a long process. This makes setting a time frame for healing a highly individualized thing. Next, I will discuss my database researches. I also struggle with the databases because I was kind of surprised to find that there is actually not a large amount of data and studies comparing negative pressure wound therapy with installation to standard negative pressure wound therapy. I found the most articles that applied to my topic from CINAHL and PubMed. I will first analyze the CINAHL database. I searched for negative pressure wound therapy with installation and negative pressure wound therapy. First, I received 27 results. Then I applied full text as a filter and got 2 results. I didn't have a lot of options, so I picked the most applicable articles to my research topic. Second, I will analyze the PubMed database. I searched for negative pressure wound therapy with installation. I first received 119 results. Then I applied full text published within the last 10 years in human subjects as my filters. These filters narrowed my results to 66 articles. This database did give me more results to choose from, however, I still chose articles that were most applicable to my research topic. Now I'll break down my chosen articles. My first article was my highest level of evidence, which was level 1. This study was a randomized controlled trial. The study included 19 patients with 20 chronic wounds. 10 wounds were randomly assigned to receive therapy with installation, and 10 wounds were assigned to receive the standard therapy. Biopsies were completed pre-debridement, post-debridement, and 1 week after the study began to test for bacteria in the wound bed. The negative pressure wound therapy with installation group were treated with a dilute sodium hypochlorite solution. The study concluded that negative pressure wound therapy with installation reduced overall bacterial bioburden in chronic wounds when compared to standard therapy. My second article was Level 3 evidence. This was a comparative study which included 142 patients with various types of acutely and chronically infected wounds. 34 patients were treated with negative pressure wound therapy with installation with the 6-minute dwell time, and 34 patients were treated with the 20-minute dwell time. The remaining 74 patients were treated with the standard negative pressure wound therapy. The study concluded that negative pressure wound therapy was more beneficial than the standard therapy and required patients to have fewer surgical debridements and decreased length of stay. My third article was also Level 3 evidence. This was a comparative study which included 20 patients with acute lower leg wounds. 10 patients were treated with negative pressure wound therapy with installation with sterile saline, and 10 patients were treated with the standard negative pressure wound therapy. The study concluded that negative pressure wound therapy with installation helped to decrease length of hospital stay and accelerated wound healing. However, the results were not statistically significant, and more studies, such as randomized controlled trials, need to be completed for more conclusive data. My fourth article was also Level 3 evidence. This was a randomized comparative study which included 13 patients with 16 chronic lower leg and foot wounds. All the wounds were surgically debrided, then 8 wounds were treated with installation of Dakin's solution, and 8 wounds were treated with the standard negative pressure wound therapy. Cultures of all wounds were obtained before surgical debridement, immediately after surgical debridement, and 7 days post-debridement. The study concluded that wounds with negative pressure wound therapy had less bioburden than negative pressure wound therapy alone. My fifth and final article was a case study which was Level 4 evidence. This study included 4 patients with varying types of chronic wounds. 3 wounds were pressure ulcers, and 1 wound was necrotizing fasciitis. Each patient had received many dressing treatments in the past, which included but was not limited to silver dressings and wet to dry dressings. All these dressings had failed to adequately heal the wounds. All the patients were then treated with negative pressure wound therapy with installation with dermamycin for the purpose of this study. The study concluded that negative pressure wound therapy with installation was effective when compared to other dressing types. Negative pressure wound therapy with installation provided enhanced wound progression without major complications, decreased hospital stay, and decreased bioburden of the wound. Here's a picture from that study which shows a coccyx wound after surgical debridement and after 3 weeks of use with negative pressure wound therapy with installation. Next, I will address the similarities between my research articles. Most of my studies were Level 3 or Level 4 types of evidence, except for one study which was Level 1. It was pointed out to me in one of our previous assignments that all of my studies were Level 3 or Level 4, so I searched for an article that would be a higher level of evidence, and I found an article that was Level 1. All of my studies were completed within the last 5 years. Although all of my studies were retrieved from CINAHL and PubMed databases, of course, all of the patients had wound, and this was the only inclusion criteria that I really found for all of my studies. All the participants were adults. All my studies compared negative pressure wound therapy with installation to standard negative pressure wound therapy or other standardized treatments such as wet to dry dressings or silver dressings. And almost all of the studies were completed following a surgical debridement and then followed the progress after that. Here I have another picture from a study that is showing a picture of a wound after surgical debridement, after 9 days of treatment with negative pressure wound therapy with installation, and then the installation therapy actually prepared the wound to be able to be grafted, so the third picture is the wound after grafting. Next, I will discuss the inconsistencies within my article. The main inconsistencies I found were just the varying causes, sizes, locations, and types of wounds. Some of the causes or etiology was pressure ulcers, diabetic ulcers, venous stasis ulcers, necrotizing fasciitis. Sizes, they were large wounds, small wounds, medium wounds, all sizes of wounds. And the locations were lower leg wounds, foot wounds, and gluteal wounds. This, to me, provides a variable amount of reliability and repeatability for my studies just because there were so many variables. There also were acute and chronic wounds. There was different types of solutions and amount of solutions instilled. Some of the types were duramycin, Dakins, 0.125 sodium hypochlorite, and saline. The amount of installation is dependent upon the size of the wound bed because the solution needs to fill the entire wound bed. Another inconsistency was the different length of dwell time. I found 6-minute dwell times, 10-minute dwell times, and 20-minute dwell times. The dwell time is dependent upon the amount of infection that is present in the wound and the amount of time that's needed to adequately clean the wound. Also, another inconsistency was different amount of negative pressure applied. The pressure that is applied is dependent upon the location, size, and type of wound. All these things affect the quality of the seal that the dressing is able to achieve. Also, there were so many different comorbidities involved in all the studies, such as diabetes, chronic kidney disease, hypertension, deep vein thrombosis, traumas, arterial insufficiency, and history of cerebral vascular accident. Next, I will discuss the gaps and limitations in my research. Most of the studies included small sample sizes. There were limitations in reliability and consistency of the findings and of the variables in all the studies, like I previously mentioned. There was a lack of randomized controlled studies, which could increase the risk of bias towards negative pressure wound therapy with installation. All my studies were level 3 and level 4. There are many inconsistencies in the types and size of wounds involved in the studies. I also found very small to no inclusion or exclusion criteria within each study. The application of negative pressure wound therapy with installation dressings itself is a complex and sterile procedure that can greatly affect the overall healing process. In one of my studies, there actually was an error in application which caused a failure and reoccurring open wound. Because of this, the patient had to be transferred from the installation group to the non-installation group. Also, a limitation that I found just with doing my own research is the relatively small amount of studies found on the databases. Cochrane and AHRQ only gave me 6 results, and that was before filters were applied. In conclusion, I believe that there is a strong amount of evidence supporting negative pressure wound therapy with installation, and I believe that it is beneficial and more effective than the current standard, which is negative pressure wound therapy without installation. The benefits I found are decreasing amounts of bacteria in the wounds, promoting tissue granulation formation, accelerating wound healing, reducing the average number of surgical debridements and hospital stays, and a decrease in healthcare costs associated with wound care. There is evidence that supports using negative pressure wound therapy with installation instead of negative pressure wound therapy when there are no contraindications. However, I believe that there still does need to be more studies, such as randomized controlled studies, done about this comparison in order to best show and reiterate the benefits. I was unable to find a guideline for negative pressure wound therapy with installation. With more research, I believe evidence supports implementation of a guideline to make negative pressure wound therapy with installation the new standard instead of negative pressure wound therapy. Here are my references.